Welcome to the webinar titled ASH 2022 Update on MDS and AML. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. The foundation has many educational opportunities, and I'd like to let you know about a few of our upcoming programs that may be of interest to you before we get started with the webinar. Each year, we host patient and family conferences throughout the year. Our first conference is coming up on April the 15th in Omaha, Nebraska. All of our conferences are hybrid, so you can join us in person. If you can't join us in person, you can still participate from the comforts of home. Registration is currently open for the April 15th conference, and you can find more about all of our conferences and how to register on our website. If you're interested in connecting with other MDS patients and families, we do offer virtual support groups. We are hosting a virtual MDS support group this Saturday, April the 8th. You can register on our website, and once you register, you will receive a confirmation email. In that confirmation email, you'll find the Zoom information to be able to participate in the group. Each year, some of our wonderful volunteers organize and host our March for Marrow walks. These are walks that help bring awareness to communities and also help with raising funds for our educational programs and other opportunities here at our foundation. Our next walk will be in Long Beach, California, and will be on Saturday, April the 29th. All of this information about our upcoming events you can find on our website, which is aamds.org. While you're participating in the webinar today, if you should lose your connection and you cannot view the program online, you can still call in to hear the audio portion using the call-in number in your reminder email. The program today will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window. When you finish typing, just hit enter, and we will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming question. Please submit your entire question all at the same time. But please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our speaker today is Dr. Lourdes Mendez. She received her medical degree from the Albert Einstein College of Medicine, as well as a PhD in cell biology. She completed her residency at Weill Cornell, New York Presbyterian, and while a fellow in hematology oncology at BIDMC, she undertook a postdoctoral fellowship in cancer genetics. Most recently, she was an instructor of medicine at Harvard Medical School and the leukemia program director at BIDMC. She is dedicated to both the clinical care of patients with myeloid disorders and translational research to identify novel therapeutics in high-risk myeloid neoplasms and improving clinical outcomes for patients. It's my extreme pleasure to welcome Dr. Mendez. Thank you so much for joining us.
Thank you very much for having me. don't think that you can see my slides. Is that right?
Not yet.
Okay. Can you see now?
Yes. They're in presenter mode. Thank you so much.
Okay, thank you. All right, well, it's a pleasure to join you today to provide updates on MDS and AML from ASH 2022, as well as some updates more broadly in our field. I have no disclosures that are pertinent to this presentation. And today we're going to talk about updates on the classification and prognostication as pertains to MDS, as well as the management or treatment, in particular of lower risk MDS, but also touching on higher risk MDS. And last but not least, new directions and exciting results on new directions for the treatment of AML. So it always helps to start at a common place by reviewing what MDS and AML are. And these are malignant disorders of the hematopoietic system, and that lead to poor production of red blood cells, white blood cells, and platelets. And so these cytopenias are the hallmark of myelodysplastic syndrome, or MDS. But in the case of AML, there's also a problem of overproduction of immature blood cells that are referred to as stem cells or progenitor cells when they're normal, but are referred to as blasts in the case of a myeloid neoplasm like MDS or AML. And MDS and AML are problems that largely afflict older individuals. So the median age of diagnosis of MDS is between 71 and 76 years of age. And it's not a common condition. There are approximately 20,000 people who are diagnosed yearly with MDS. And different from AML, which has a pretty uniformly aggressive course, MDS is variable, and the clinical presentation and the clinical course are heterogeneous. However, 1/3 will progress to acute myeloid leukemia that is also called secondary AML. And the statistics are similar for AML. Like MDS, it's not common. There's an estimated 20,000 new cases in 2022. And the median age here is a little bit younger, but still it's a condition of older adults. And of course, this is not exclusive. There are younger individuals who contend with MDS and AML, but the median is in the 60s to 70s. As I mentioned before, just a moment ago, there is an entity that's called secondary AML, and there's also secondary MDS, because these two diseases can be broadly categorized as primary or as secondary. And primary means we don't know why it happened. It's new or de novo. And this is most of MDS cases. But there are MDS that come following treatment like radiation therapy or traditional chemotherapy. And these are called secondary MDS cases. And there is a period in between when the so-called insult or damage to the DNA occurred and when MDS or AML is detected. And secondary MDS and AML are more traditionally more difficult conditions and are associated with complex DNA changes called cytogenetic abnormalities. So it's worth spending a few minutes to review together the concept of genetic mutations. So the depicted here is a chromosome, and the chromosome consists of many genes. And when we talk about genetic alterations, we're talking about lesions on the DNA. So damage to the DNA, and it can be a small damage, a molecular damage, or can be a larger damage, resulting in a change in the appearance of the chromosomes, or duplications or losses of chromosomes. And people often wonder why does this happen? And actually, this is a process that starts from the moment that we're born, and even earlier. But the body has many systems to repair this damage or these mutations, or to eliminate cells with DNA damage. However, those mechanisms sometimes fail, and then there are cells that contain DNA mutations. And if the mutation hits a gene that can be cancer causing, then the cell has the potential to become a cancer cell, including of the hematopoietic tissue. And there's two types of mutations, broadly speaking. There are those that are called somatic, and these are acquired mutations, not ones that are inherited. And there are germline mutations, and these are inherited. And the ones I'm going to refer to today are all somatic mutations. And this is just a representation of what historically was the mainstay for acquiring genetic information on MDS and AML. This depicts a karyotype, and this depicts results from a technique called FISH that if you've seen reports, you may have seen described, particularly as part of bone marrow biopsy results. But more recently, in the past 10 years, we have, through next generation sequencing technologies, been able to acquire a compendium of molecular mutations in MDS and in AML. And this has allowed us to refine our understanding of these diseases, but also the way we classify them, because different genetic subtypes of MDS and AML are associated with different outcomes and different risk. And so on the right, this is from the ELN 2022. This is the updated version of the AML prognostic classification system. And so now we are going to touch upon updates on the classification of MDS in particular. So in the last years, we've really been employing the World Health Organization classification to diagnose and classify subtypes of MDS and AML. And there was in 2022 a new edition of this WHO classification system that was published. But in addition, for the first time, there was a classification system called International Consensus Classification System that was also provided to the community. And this creates a unique situation because we, at the present time, have two classification systems. And they do have overlap, but they also have points of divergence. And a place where they do coincide is in emphasizing that there are genetically defined subtypes of MDS. So MDS with SF3B1 mutation, MDS with deletion 5q, and MDS that has mutated TP53. However, what's unique to the ICC system is a category that collapses MDS with increased blasts that are 10% or greater, and AML. And so this is new, and this is different from the WHO system, where they preserved this distinction that we had previously between 5 to 9% blasts and 10 to 19% blasts. And they just changed the nomenclature to be increased blasts instead of excess blasts. In addition, the WHO system created some new categories hypoplastic MDS and MDS with fibrosis that is not included in the ICC. And so if you're looking at a report and see kind of two different diagnoses, this is why. And we're hoping that these two systems will be reconciled sooner than later. So many of the studies that were reported at ASH had to do with validating these classification systems. And this is one example by Ball and colleagues. And they did validate these two systems and showed that they had strengths and would benefit from probably pulling the best points from each system. In both cases, these genetically defined or molecularly defined entities that I was talking about were proven to be unique, and not surprisingly, TP53 mutated disease was very predictive of survival, unfortunately, poor survival. This new entity that I talked about, which is MDS with fibrosis, was shown to be associated with worse overall survival in the MDS increased blast group. And there's ongoing efforts to validate these classification systems within the international consortium for MDS. So this flows right into the importance of separating out different types of MDS in terms of the risk that they pose. And so there's several risk stratification systems, but the ones that really are probably best known are the IPSS and the revised IPSS. And as far as clinical trials that are currently accruing, most of them make use of the IPSS-R, which we've used to separate patients into lower and higher risk MDS with different management strategies for each. And a long-awaited update to the IPSS system that incorporates molecular genetic information was published in 2022 and is called the IPSS-M, M for molecular. And it does away with the intermediate category, and there are just 3 low categories and 3 high categories, which makes management a little more clear. Since what to do with intermediate has always been the subject of debate. And compared with the IPSS-R, it re-stratified almost half of patients. A very accessible calculator can be found at this website listed on the bottom right. And what you see, on the right-hand side are how these groups separate out patients into different outcomes in terms of overall survival and leukemia-free survival. And that's what we want in a prognostic system, is a nice separation of those curves. And so again, at ASH, there were efforts to validate this IPSS-M risk stratification system, such as with the Genome Med cohort, which did validate the IPSS-M. And so this is rapidly becoming the standard of care in terms of risk stratification. So moving on to treatment options, specifically for MDS, we discussed that this is a diagnosis that's very variable in terms of the clinical course. And so the treatment options are appropriately also varied and range from watch and wait in someone who has mild low blood counts and has no symptoms, all the way to a allogeneic stem cell transplant, which remains the only curative treatment for MDS. These are listed kind of in increasing intensity. And at the point of hypomethylating agents is kind of the separation between management for lower risk MDS and for higher risk MDS. For higher risk MDS, the objective is to alter the course of the disease. So there were several talks and posters at ASH that were very exciting on improved strategies for the treatment of significant anemia in patients with MDS. So more than 80% of patients with MDS will need a red blood cell transfusion during the course of their lifetime. And as the need for transfusions increases, this decreases quality of life and can even shorten lifespan through complications such as iron overload. And a cornerstone of frontline treatment for transfusion-dependent MDS has been the erythropoietin stimulating agents, which are growth factors that stimulate red blood cell production, such as epoetin alpha and darbepoetin. And there's a different agent that was approved more recently, luspatercept, and it functions differently from these ESA agents. It enhances late stages of erythropoiesis by acting as a ligand trap for TGF-beta family, superfamily of ligands. And in trapping these ligands, it inhibits ineffective red blood cell production. And based on data from the MEDALIST trial, luspatercept is approved for the treatment of low-risk MDS with ring sideroblasts in individuals where erythropoietin stimulating agents have failed. And one of the abstracts at ASH that was reported was a real-world validation of the outcomes reported by the luspatercept trial, the MEDALIST trial. And highlighted here, you can see that individuals who started out with low transfusion burden converted to transfusion independence, and this was 92% of these patients, which is a very robust number. And in those who started out with a greater transfusion burden, there was a conversion in all to lower, to a decreased need for transfusions, but not quite to transfusion independence, which kind of highlights the idea and the importance of testing active agents earlier in disease once we have experience with their efficacy and safety. And that is the objective of the COMMANDS trial, which tested luspatercept frontline, comparing it to ESA in individuals with low-risk MDS, here with or without ring sideroblasts who are transfusion dependent. So here you see the comparison of luspatercept and ESA. And this wasn't reported at ASH, but it was a press release, and again, very encouraging. This trial met its primary endpoint of achieving transfusion independence, red blood cell transfusion independence for 12 weeks. And so creating optimism that luspatercept will move up to the frontline setting. So moving now to a different type of treatment, an immunomodulatory agent, lenalidomide, which you may know is approved for the treatment of MDS with deletion 5q in individuals who are transfusion dependent, with very high response rates in this group of patients in terms of achieving transfusion independence. And the Sinatra REV trial is a randomized phase 3 trial of moving lenalidomide earlier in the course of disease. So a similar theme here. And these patients that are being treated are anemic, but they're not transfusion dependent. And in fact, the threshold for treatment is just a hemoglobin of less than 12, but it is again the deletion 5q low risk MDS patient group. And so here lenalidomide is compared to placebo, and this is a lower dose than was used initially in the studies that led to the approval of lenalidomide in deletion 5q low risk MDS. And you'll notice that there is a finite period of treatment that's defined and studied by the trial. So 2 years. And what was reported at ASH was a really striking difference in the time to transfusion dependency with treatment of this patient group. And so lenalidomide decreased by 69.8% the risk of transfusion dependence. And you can see how that it's really prolonging the time to needing red blood cells for years. And so this is a very striking finding that strongly suggests that the way we use lenalidomide is going to change in the near future. Importantly, there were no new safety signals that arose by moving lenalidomide up prior to the need for transfusions. And Dr. Toribio Castillo and colleagues reported on a very interesting effort to molecularly profile these patients before and during treatment and after treatment, and concluded that lenalidomide did not promote clonal evolution, which is an important aspect of treatment with lenalidomide. Nope. Seem to be. Okay, so moving on to a different agent, imetelstat, which is a first-in-class telomerase inhibitor. So telomerase is upregulated in transformed hematopoietic stem progenitor cells, and inhibiting this aberrant telomerase activity has the potential to lead to cell death of the malignant cells and to improve blood counts. And so this was previously published by Steensma and colleagues in 2020 in JCO, showing that treatment with imetelstat provides durable transfusion independence in non-deletion 5q low-risk MDS that had progressed on ESAs. And this is the phase 2 portion of the eMERGE study, showing that hematologic improvement was achieved in 68% of patients, including 29% who had transfusion independence at 24 weeks. And so from this phase 2 portion, Dr. Plotzbecker and colleagues reported on the characteristics and clinical benefit for the subgroup of patients who experienced transfusion independence for more than a year. So this was a small group of 11 responders, but strikingly, they had a median transfusion independence duration of 92.4 weeks, with a very substantial mean change in hemoglobin that was approximately 3 grams per deciliter. And so this data suggests that in a subset of patients, this drug may really modify the disease course. And this is one of the most exciting agents that's currently before the FDA for MDS. Here too, there was a press release of the phase 3 portion of the trial, and happily it was positive, with 39.8% of patients receiving imetelstat compared to 15% receiving placebo, achieving transfusion independence at 8 weeks. So there's a lot of optimism that this agent may enter the standard of care. So moving on to higher risk MDS, the kind of mainstay of treatment for higher risk MDS has been hypomethylating agents, including azacitidine, decitabine, and oral decitabine. And that's in part because of data like that reported now in quite some time ago in 2009, indicating that there's a survival benefit to azacitidine compared to conventional care. Here in this paper up to 24.5 months. But unfortunately, this type or this level of benefit has been hard to reproduce in the real world. And so there's a lot of work to be done to improve outcomes with hypomethylating agent monotherapy. And this is a list of a few of the randomized phase 3 trials in frontline management of high-risk MDS that we're awaiting the results from. Those highlighted in Black, unfortunately, have not met their primary endpoint, but we look forward to the results of these other agents in combination with hypomethylating agents listed here. And it's very important to take a moment to highlight that hypomethylating agents in individuals with high-risk MDS who are fit is really a bridge or a intermediate step on the road to allogeneic stem cell transplant, which, as I had mentioned before, is the only known curative treatment still for MDS. And we have now robust data comparing individuals who had a donor available compared to no donor available that demonstrates that the 3-year overall survival is 47.4% in those who went to transplant versus 16%. And so individuals who are fit need to be promptly referred for transplant evaluation, and age alone should not preclude that. So one of the most promising combinations with hypomethylating agent is that of venetoclax and azacitidine. Dr. Garcia reported at ASH 2021 the phase 1b efficacy results, which compared very favorably to historical results with very high response rates in many different genetic subtypes of MDS. And Dr. Zaiden reported also at that same meeting the activity in relapsed refractory MDS, which is an area of significant need, again, across many different types of genetic subtypes. And a different approach, which is proceeding in parallel to combining HMAs with targeted therapies like venetoclax, is combining them with immune checkpoint inhibitors. And the rationale here is that malignant cells utilize many strategies to restrain and neutralize their microenvironment, specifically immune cells that would otherwise try to eliminate them. And so the objective is to interfere with these mechanisms by targeting different checkpoints. And so an interesting target, an agent, are TIM3 and sabatolimab, which targets TIM3. And TIM3 is expressed on the malignant cells, but not on hematopoietic stem cells. And it's also expressed on immune cells like T effector cells. And so the ideal, as with other immunotherapy, is to release the brakes on the immune system in parallel with targeting the malignant cells. And based on encouraging early phase results, the Stimulus MDS-1 study was launched. This is a phase 2 randomized double-blinded placebo-controlled study, the results of which were reported by Dr. Zaiden from our institution at this last ASH. And the patients that were studied were very high or intermediate risk for the IPSS-R system. And it was randomized comparing sabatolimab with decitabine or azacitidine compared to placebo with the same. And the primary endpoint was an improvement in CR or progression-free survival, which unfortunately in this phase 2 study was not met. But there was an interesting observation, which is that the combination may have a delayed onset in terms of progression-free survival benefit. And that is represented in this graph here, where you see that patients who are responding and received sabatolimab had a much longer duration of response, which is particularly striking for those patients who achieved a CR, where the response is approximately double. And so it may be that some immunotherapies like sabatolimab have a role in maintaining a good response and not in increasing the rate of response. Another very exciting checkpoint inhibitor is magrolimab, which targets CD47, which is the famous "do not eat me" signal that restrains macrophages, which would otherwise try to eat or phagocytose abnormal cells. And the combination of magrolimab and azacitidine has shown promise in high-risk MDS. And at this past ASH, Dr. Zaiden spoke about the rationale for a trial that is going to combine oral decitabine with magrolimab for the frontline treatment of higher risk MDS patients. And we look forward to hearing about the results of this trial. So just in terms of MDS, the treatment algorithm has some complexity, and there's some of the data that I've mentioned suggests that some of our existing tools for the treatment of lower risk MDS may be able to move up to the frontline setting, or at least earlier in the treatment course, and have kind of a bigger bang for the buck, so to speak. And in addition, there's many trials, some of which I touched upon, but some of which I have not, such as azacitidine and the super retinoic acid receptor agonist tamibarotene, that are underway, exploring whether we can improve outcomes in high-risk MDS. And so our site is participating in this trial, in the oral decitabine and magrolimab trial that I mentioned. We also have an expansion phase trial with imetelstat and a trial testing a different agent for this checkpoint with CD47 "don't eat me" signal. So now moving on with the remaining time to treatments for AML. So it used to be that we had kind of a binary situation where the options for induction for AML were either intense treatment with traditional chemotherapy versus low intensity treatment with hypomethylating agent monotherapy. And in 2017 was the start of what's been termed a therapeutic revolution in AML, very happily for those of us who treat this condition, where the toolbox really expanded in terms of approvals for different subtypes of AML, many of which are listed here. But despite this, there remain several unmet needs, one of which is the frontline treatment of older patients with AML who have many comorbidities, where we really seek to build upon the activity and the benefits that we've seen with doublet therapy, meaning a treatment with venetoclax and azacitidine or decitabine, which in the majority of patients still don't lead to a remission that's long enough. In addition, we have other subtypes like TP53 mutant AML, where the response rates and in particular, the duration of response and survival are really continue to be suboptimal. There's always the problem and the goal of expanding the options for relapse refractory AML. So Dr. Daver and colleagues reported on the results of the phase 1/2 study of a triplet, azacitidine, venetoclax, and the agent we were just talking about, the Don't Eat Me signal inhibitor, magrolimab, in both newly diagnosed and relapsed refractory AML. And in the interest of time, I'm just showing here response rates in the frontline cohort. And you can see very high response rates across the board. This is separated out into de novo AML and into secondary AML. And then it's also separated out in terms of the TP53 mutation status, whether it's wild type or mutant. And while the wild type results are a bit better, they're very robust results in the TP53 mutant patients as well. And in the frontline setting with the combined de novo and secondary populations, there isn't quite the significant improvement in median overall survival that we would hope for compared to historical controls. But when you take just the de novo population, you see a 12-month overall survival of 53%, which does compare favorably to historical numbers in this subtype of patients. So a different triplet, again in a high-risk subtype of AML, a subtype that also represents an area of unmet need. FLT3 mutated AML was reported by Dr. Short on behalf of investigators. And this was updated results of the phase 1/2 study studying the triplet azacitidine, venetoclax, and gilteritinib. And this is both in relapsed refractory FLT3 mutated AML and newly diagnosed FLT3 mutated AML. And the relapsed refractory cohort included high-risk MDS or CMML. And this is the induction regimen. And interestingly, or rather notably, compared to what we do with doublet, there was a bone marrow planned at day 14 for the purpose of assessing response. And if there were less than 5% blasts, venetoclax was held in both cohorts, and gilteritinib was held in the frontline cohort only. And this speaks to the fact that it's very important to be cognizant of myelosuppression when there's 3 agents employed. And here again, moving to the response rates, I'll just mention there was no signal of increased early deaths, speaking to the safety of treatment with triplet therapy. And in the frontline cohort, there was 100% response in terms of the combined CR, CRI, and morphologic leukemia-free state. And in the relapse refractory cohort, there was a 70% response rate, which is very encouraging. And consistent with this, there was an 85% one-year overall survival that was observed in the frontline cohort. And this compares very favorably to the historical experience with just the doublet HMA and venetoclax. So moving on to the last class of agents that we will touch on. These are menin inhibitors that interfere with the interaction between menin and KMT2A, which was previously called MLL. So this interaction promotes leukemogenesis, it's thought, by interfering with the ability of cells to mature, which is also called differentiate. And this mechanism seems to be particularly important for KMT2A rearranged MLL, but also for NPM1 mutated AML, which represents a substantial amount of MLL. And Dr. Isa presented on the Augment 101 study, which is a phase 1 study of the menin inhibitor revumenib in patients with these 2 subtypes of MLL. Being a phase 1 study, there was the primary objective was largely to characterize the safety. And there was a notable frequency of QTC prolongation that was observed at all grades, and in 10% of patients, grade 3 and higher. So this will have to be monitored. But in terms of response, there was quite some encouraging results, because this is a heavily pretreated group of patients, and nonetheless, there was a 30% combined CR rate with responses in both subtypes of AML, favoring a bit the KMT2A rearranged group with this agent. A different menin inhibitor, ziftomenib, was studied in a phase 1/2 first-in-human study, again in relapsed refractory AML in the COMET trial reported by Dr. Erba. And interestingly, with this agent, no QTC prolongation was reported, but you may remember that I mentioned the preclinical studies indicate that menin and MLL interaction blocks maturation or differentiation. And so consistent with restoring this process, differentiation syndrome was observed as an adverse effect of this treatment. And again, there was very encouraging anti-leukemic activity with a 30% CR rate observed in the NPM1 mutated group and a more modest response in the KMT2A group. So very encouraging, and have in a group of patients that's heavily pretreated. And as a result, these agents are now being tested in combination with our approved therapies. And so to conclude, we have talked about the significant impact on transfusion needs that's been reported for luspatercept in low-risk MDS that is not yet refractory to ESA, and the very interesting possibility of moving lenalidomide upfront prior to the need for transfusions to prolong, potentially by years, the need for transfusions in the group of deletion 5q low-risk MDS. We talked about imetelstat, which is one of the most exciting investigational agents in this space. Phase 3 trials that we are eagerly awaiting the results of with significant optimism. And then we touched upon a few triplets and also novel agents like the menin inhibitors that also give us cause for optimism in terms of potential new additions to an increasingly complex, but also an increasingly generous in terms of options, treatment algorithm for AML. And with that, I thank you for your attention, and I'm happy to take questions.
Thank you so much for the wonderful presentation. We have a few questions, and our first question is, in my own experience and from what I've seen in Facebook groups, patients can receive differing diagnoses based upon repeat bone marrow biopsies, some even suggesting spontaneous remission. Have you seen this in your own experience? Is this just likely the result of a low-level disease caught early, and that one should or could expect disease progression?
So I'm not sure if this refers to MDS or MDS and AML, but I can, since it specifically asks about my own experience, I can say that I personally have not seen neither MDS nor AML spontaneously regress. I have heard from colleagues that there are case reports of this, but this is, exceedingly rare. This is not a phenomenon that would have really kind of a reportable frequency. And so for the really overwhelming wouldn't begin to capture it. But, once there is kind of evidence of MDS or AML on a bone marrow biopsy with all the standard of care studies, that's pretty definitive for that diagnosis. So, what's changing is what we call when we are catching things earlier with the increasing use of next generation sequencing. So we are catching precursor conditions, but the classification systems do draw a line and a distinction between precursor conditions and MDS, and the precursor conditions are something that we're still learning a lot about, and whether some types of chip may have a fluctuating course is something that remains to be defined and has been published for JAK2 chip.
Thank you very much. Our next question is, are all of these encouraging advances in drug treatment going on with the ultimate goal of not needing stem cell or marrow transplants?
That's a very good question. And I'm very happy to get that question. Right now, for patients where transplant is not an option, whether that be because of, there is a point where age does start to limit the potential use of transplant. And even before that, as I discussed, depending on coexisting problems, transplant may not be advisable. And so for that group of patients, these new developments is meant to prolong survival. And we would hope that at some point we would have combinations that might supplant transplant. But for people who are able to go to transplant, they're not meant to replace transplant right now. They're actually meant to get a greater number of people to the point where transplant is an option. Because, for example, in people who have increased blasts, most of us would treat that person and wait to embark on transplant until the moment where there are no increased blasts. And not everyone with our existing therapies will get there. And so the objective for so-called fit patients is to get ideally all of those patients to the point where they could go to transplant. We know outcomes in general are best when the disease is at the lowest level that we can get it to before transplant.
Thank you for that. Our next question is, are there any drugs or trials focused on monosomy 7?
That's a good question, because that has definitely been difficult biology. To my knowledge, there aren't specific treatments targeting this genetic subtype of MDS, or this is found in AML as well. So to my knowledge, no. But I think it's worth stating that the treatment that I call doublet, which is hypomethylating agent and venetoclax, has been reported to be effective in people with complex cytogenetics, which deletion 7 is often a part of, and that the people who really have the suboptimal outcomes with this doublet are those who additionally have TP53 mutation. So I think that that's a very interesting finding that was published in more or less the last year.
Thank you. Our next question is, Are combination therapies the future of treating MDS versus treatment with single agents?
I think that's definitely the future of treatment for higher risk MDS, where we're building on the significant improvements, that have been seen in AML and trying to bring them to patients who have high risk MDS. The question was for MDS, right?
Yes.
Yes. So I think most of us are really envisioning a future where there is it's combination therapy, and we have to get to the point of doublets first. AML is doublets have become a standard of care, but for MDS, we're hopefully going to get there soon, and then start to talk about triplet therapy. But I do think that that's our future.
Thank you so much for that. Our next question is, can you define what is meant by refractory and relapse disease for MDS?
Oh, okay. So relapse refers to losing a response. So for example, if a complete response or remission was attained and then lost, that's called relapse, whereas refractory refers to not achieving a response, disease that is resistant to a kind of therapy. And I think I referred to those terms several times. And for MDS, I refer to relapse or refractory disease to the ESA agents, for example. So an example of refractory disease is if someone gets 8 weeks of darbepoetin and there's no improvement in transfusion needs or no improvement in the or there's no transfusion independence. So that's refractory, whereas relapsed is if there is improvement for a period of time, and then that's lost.
Thank you so much. And another term you used was transfusion dependent. What defines a patient as being transfusion dependent?
Transfusion dependence means that there is the red blood cell production has become low enough that the individual can't make enough red blood cells to maintain a safe hemoglobin level. And so depending on the institution, that threshold is set somewhere between 7 and 8. And so when the hemoglobin slips below that point, then we offer red blood cell transfusions. And unless something else is in the mix, like blood loss from bleeding, which can certainly happen, you can have more than one problem. But assuming that that's not part of the situation, then once that someone starts to need red blood cell transfusions, it becomes an ongoing need. And that's what's referred to as a dependence on transfusion. So it's a dependence to meet that level of hemoglobin that is felt to be safe. Sometimes the transfusion, the trigger for transfusion is symptoms and not just the number, or it can be informed also by someone's medical history. So if there's a very significant history of coronary artery disease, for example, and someone has chest pain that can be provoked by anemia, then we will more readily transfuse someone like that. But dependence means an ongoing need for red blood cells.
Thank you so much. And this question comes from a newly diagnosed MDS patient. and they are discussing their treatment plan as used with NCOV and transfusions to supplement as needed. They'd like to know why would NCOV be recommended for a patient? Like under what conditions is NCOV recommended for what type of MDS patient?
So in COVID was shown to be non-inferior. So NCOV is an oral version of decitabine with the additional drug that prevents it from being destroyed as a part of the digestive process. So it's shown to be non-inferior to the IV formulation that we've been using in MDS and in AML. So that, and as well as in CMML. So that would be the kind of on-label indication for this drug. It may be being used off-label because I don't know about the situation, but it's possible that at times it's used off-label because we do use hypomethylating agents in low-risk MDS if we've exhausted other options, or sometimes for thrombocytopenia where we have few options to address severe thrombocytopenia and dependence on transfusions. Does that seem to answer the question?
Yes, thank you so much. And thank you so much, Dr. Mendez, for your time and sharing all of your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. You'll also receive an email from us letting us know that the webinar is up and ready for you to watch. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org. Give us a call at 800-747-2820, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our program.
Thank you.